Um, we're just about to start now. So we usually have lots of participants from all around the continent, and it really is a pleasure for us to have the head of audiology and chief audiologist at the Red Cross War Memorial Children's Hospital, Silva Kuschke, join us today and share with us some of her findings about hearing loss in pediatrics in South Africa. I think this topic is going to be very relevant to those of us practicing in developing settings. So just before she kicks in, just some house rules. If we can just keep our microphones on muted throughout the presentation. If you have a question, you can use the chat function and type in your question, or if you want to ask it personally, you can go ahead when I give you the cue. And if you haven't registered already, please, if you can just put your name, institution, and country and your email address just on the chat function. Okay, fantastic. I think we have 41 participants, Silva, and I think more will join us as we go on. But please, welcome again to our platform, and thank you for your time today.
Thank you so much, Tasir, for the warm welcome. And thank you very much for the opportunity to present my research on this platform. I'm just seeing Zimbabwe, Ghana, Ethiopia, Nigeria. I feel very privileged to share this information on such a wide platform. So thank you for the invitation.
You're welcome.
Right, I'm just going to share my screen. Here we go. Can you see that, Tasir?
Perfectly fine, Silva.
Okay, perfect. All right. So this research of mine is actually part of my PhD that I'm busy doing through the University of Pretoria. And this is the first article that has come out of that research. And it's about describing the profile of childhood hearing loss in a cohort from Red Cross War Memorial Children's Hospital in Cape Town in South Africa. Let me just go to the next slide. I'm not sure why it's not going. I'm so sorry to see it. Let me just see why it's not happening.
No problem. You may need to just click it manually next with the arrows.
Okay, I think, sorry, let me just see, here we go. All right. So throughout the presentation, I'm going to be using a few acronyms, and here is a list of definitions of those acronyms. Please, if you are unsure of what I'm talking about, you can just unmute and ask me, and then I will clarify. And then any questions that might arise, you can just put them in the chat box and I'll answer them after the presentation. So this is just a link to the publication that appeared in the International Journal of Pediatric Otorhinolaryngology in July this year. And yeah, if you want to go and read the full article, you can find it here. So just a little bit of background on the study. Hearing loss, and specifically hearing loss in children, is a global epidemic. And I'm not saying that word lightly, considering the situation that we face currently globally with COVID-19. But 34 million children worldwide have hearing loss. And almost half of those children are under the age of 5 years, making hearing loss the second most prevalent developmental disability. And untreated hearing loss, specifically in children, has severe devastating effects on their speech and language development and their ability to one day become, contributors, economic contributors to society. So that was kind of the rationale for me of doing the study, just because we have very limited information in South Africa about what the picture or the profile of hearing loss in very young children looks like. So the burden of disease in sub-Saharan Africa is very high. In children under the age of 14 years, South Africa has a prevalence of 1.9%, sub-Saharan Africa, as opposed to only 0.4% in higher income countries. So the big thing for me is preventable causes of hearing loss that are so common in low to mid-income countries. They make up nearly half of all the etiologies of hearing loss in children. And this is mainly because in low to mid-income countries, we have poor healthcare infrastructure. We have a high burden of poverty, malnutrition that predispose children to illness, low immune system, a higher incidence of otitis media. These children also have much less access to non-emergency resources, such as hearing healthcare. In low to mid-income countries, there are more adverse pre, peri, and postnatal conditions which are associated with hearing loss. We have higher incidences of neonatal jaundice and low birth weight, all of which are associated with hearing loss. And we also have more vaccine preventable diseases like rubella and meningitis that can cause hearing loss than in high income countries. So my rationale for this study is because there is such a limited availability of newborn hearing screening in South Africa. And even within existing programs, there's poor data capturing and management. We don't know much about the nature and the associated risk profile of hearing loss in children in South Africa. There have been some previous studies, but they were done nearly 4 decades ago, and they were conducted in schools for the deaf, so it was older school-going children. And really only in South Africa, there are only 2 preliminary studies that were done in Pretoria in the Gauteng province on the nature and the associated risk profile of childhood hearing loss. So there's really a gap in literature, and we can't aim to treat and to intervene if we don't understand the global picture in our specific context on the profile of hearing loss in children. And my study aimed to provide one of the first reports on the profile of childhood hearing loss in the Western Cape, in South Africa, in a cohort from Red Cross. And I aim to describe the nature of hearing loss, the associated risk factors, and also the age of diagnosis of childhood hearing loss. So just a little bit about Red Cross. We are one of only 2 dedicated pediatric academic hospitals in sub-Saharan Africa. And we provide specialist diagnostic audiology and intervention services to children from birth to 13 years of age from the public healthcare sector. So these are children who cannot afford private medical, who are not on private medical aids. And in South Africa, about 85% of all patients are cared for under the public healthcare sector. So only children under the age of 6 were included in this study because there's such a big gap in literature on what the hearing profile of very young children are, children who aren't yet of school-going age. All right, so I conducted a retrospective review of all clinical data from children under the age of 6 years who were diagnosed with hearing loss at Red Cross over a 7-month period. From January to July last year. And then the data collected was demographics, type and degree of hearing loss, documented risk factors associated with hearing loss, and then the age of suspicion and diagnosis of hearing loss, which wasn't available for all children. But I'll get to that a little bit later. So we have an electronic database in our department that gets updated daily with these statistics for every patient that we see. I also just wanted to clarify the audiological test battery that we use at Red Cross. So typically, we would include tympanometry and reflex testing, otoacoustic emissions, which checks the integrity of the outer hair cells of the cochlea, behavioral audiometry, air conduction and bone conduction, specifically to determine the type of hearing loss, whether it's conductive or sensorineural or mixed. And then when children were too young for behavioral testing, or if they had a condition that precluded us from conducting behavioral testing, we used auditory brainstem response testing, so an objective measure to obtain air conduction and bone conduction thresholds. We define normal hearing as air conduction thresholds that are better or equal to 15 dBHL. And then hearing loss is when your pure tone average across 500, 1000, and 2000 decibel hertz is more than 15 dB or worse than 15 dB across your frequency. Just a note that the minimum diagnostic criteria for auditory neuropathy was present or robust otoacoustic emissions with a nice clear microphonic response. So you see that the cochlea is working, but the hearing nerve on auditory brainstem response is, you can see it's not working. It's shorting, if I can say it like that, at very high intensities. All right. Then, okay, so here's our results. So in terms of demographics, we saw during that 7-month study period, we saw 1,154 pediatric patients under the age of 6 years. And of those, 1 in 5 were diagnosed with hearing loss. So that is quite a large number, but we are a tertiary pediatric hospital, and so that makes sense. So my cohort and the rest of the results that I'm going to be describing is for those 240 out of the 1,154 patients that were then diagnosed with hearing loss, and I describe their profile in the next slides. So the mean age of those 240 patients was 42 months, with slightly more males, and the majority were of a colored background. And then we also had 28 foreign patients from neighboring sub-Saharan African countries, and Zimbabwe, Malawi, the DRC. We had those included in this cohort. Then English was recorded as the home language by the majority, followed by Xhosa and Afrikaans, which is quite a representative sample of what we see in the Western Cape. Most of our referrals, so more than half of our referrals, were from the ear, nose and throat department. They're just next to us here at Red Cross. And we have quite a large referral base from our ENTs here at Red Cross. And then medical outpatients, district referrals, genetics, CP clinic, and others constituted the rest of the referrals. So as I expected, conductive hearing loss was predominant in this sample as the type of the hearing loss. Almost more than 2/3 of children presented with conductive hearing loss, and 64% of those were mild, and almost 1/3 of those were of a moderate degree. Bilateral permanent hearing losses, so this is defined as sensory neural hearing loss, auditory neuropathy, and mixed hearing loss, made up almost 1/3 of all hearing losses. Auditory neuropathy constituted 8.3% of all permanent hearing losses, and sensory neural hearing loss was predominantly profound. More than 50% of our patients with sensory neural hearing loss had a profound degree of hearing loss. So the risk factors associated with the different types of hearing loss. For conductive hearing loss, more than 70% presented with some form of middle ear pathology, and the most prominent of these were otitis media, acute otitis media, chronic suppurative otitis media, basically middle ear disease. For sensory neural hearing loss, the biggest risk factor was a family history of hearing loss. And then for auditory neuropathy, almost all of our children, 6 out of 7, were diagnosed with hyperbilirubinemia at birth. Or neonatal jaundice. So the syndromes included in this sample was Goldenhar, T21, Down syndrome, Charge syndrome, Pierre-Robin, and Kidd syndrome. And these last 2 bullets are very interesting and also quite concerning. Is 70% of children with auditory neuropathy had 2 or more risk factors, and most of these were neonatal jaundice plus low birth weight or prematurity. And then nearly 1/3 of children with sensory neural hearing loss had no risk factors. So this is just a quick summary of the risk factors, and you can see here for conductive hearing loss, middle ear pathology was the most prevalent. For sensory neural hearing loss, syndromic causes or risk factors made up quite a large percentage, more than 10%, And this could be attributed to the fact, again, that we are a tertiary level hospital, and typically we see a lot more specialized or complex cases, including syndromic children. And then most prevalent was the family history of childhood hearing loss. And then hypoxia and CMV also constituted 10% each of the risk factors for sensory neural hearing loss. And you can see here that 85.7% of our auditory neuropathy children had NNJ, neonatal jaundice, and more than half of them had a very low birth weight of less than 1,500 grams. And then you can see our mixed hearing losses. Most of them were syndromic. So they had a conductive component and also a sensory neural component. This was most often due to congenital structural abnormalities of the ear and the face. Okay. This is just to summarize what I've said previously. So interesting to note here is that 71% of our ANSD children had 2 risk factors, and almost a third of our sensory neural hearing loss children had no risk factors. Okay. Then the age of hearing loss suspicion and diagnosis. In this subsection, I only included permanent hearing losses. So sensory neural hearing losses, there were 70 of them. Auditory neuropathy was 7, and then permanent congenital conductive hearing loss, secondary to structural and genetic etiologies, was 13. So that made up the 93 in total that we had documented age of suspicion, so parental suspicion. We would ask the parents, round about when did you suspect or were you concerned about your child's hearing? And we compared that with the actual or the time delay to actual diagnosis of hearing loss. Very interesting also to note, and devastating really, is that 50% of children who were diagnosed with permanent hearing loss were only diagnosed after 36 months of age. That is after 3 years, when we know that the speech and language outcomes are not going to be good. That golden period of neuroplasticity has already passed, and they are not going to have good outcomes for spoken language, which also will affect their schooling options and really the rest of their lives. The average delay between age of suspicion and diagnosis was 9 months. Okay. So the first point coming out of all of these results was that in this sample, hearing loss was predominantly bilateral and conductive. This is in line with the World Health Organization's literature that postulates the leading causes of childhood hearing loss in low to mid-income countries are conductive and treatable. It could also be that we have a large tertiary ENT referral base, is probably why we've seen all of these conductive hearing loss children and why they constituted such a big portion of hearing loss in the sample. But nevertheless, this finding highlights the need for awareness and training for primary level healthcare doctors and nurses in low to mid-income countries, because we need to provide effective first-line treatment for any type of middle ear disease, so that it doesn't get exacerbated and have to come or be escalated to a tertiary level hospital. And in the meantime, while these children have conductive hearing loss secondary to middle ear disease, there's often long waiting times to be seen at a tertiary hospital, and in the meantime they are not hearing properly, and it has adverse effects on their speech and language development and their schooling performance. Right. All right, so more than half of the children in the sample with sensory neural hearing loss were profound. Possible reasons for this is that the signs of profound hearing loss is much more overt than for milder or moderate losses. So parents can see that this child is deaf, and they generally tend to seek audiological assessment earlier. milder and moderate hearing losses, especially when we do not have universal newborn hearing screening, as is the case in South Africa. So these milder losses can remain undetected until they start failing at school or they start exhibiting behavioral patterns that are consistent with hearing loss. So we know that children with profound sensorineural hearing loss will not benefit from hearing aids. Even our strongest, best hearing aids are not enough for speech development. So this just drives the point home that it is so early to diagnose hearing loss early so that we can refer for cochlear implantation early, because we know that cochlear implantation has worse outcomes the older children get. And this is because of that golden neuroplasticity period of 0 to 3 years, where we know that early auditory stimulation is very, very important for optimal speech and language outcomes, especially for children with severe to profound loss who will not benefit from hearing aids. The problem in South Africa, specifically in the public healthcare sector, is that there is very limited funding for cochlear implants. And children in South Africa don't still have equal access to cochlear implants. So it's considered a privileged intervention. Right. Then, yeah, as I said, 6 out of 7 children who were diagnosed eventually with auditory neuropathy had hyperbilirubinemia, and this is the #1 risk factor for auditory neuropathy. This could also be because neonatal jaundice is more prevalent in African countries because there's a higher incidence of G6PD and there's limited treatment facilities for neonatal jaundice. Then more than half of the children in the auditory neuropathy cohort were born earlier than 34 weeks gestation with a very low birth weight of less than 1,500 grams. And then again, so the first important point is there's a lot of conductive hearing loss cases, more than 2/3, but nearly 1/3 of children with sensorineural hearing loss had no risk factors. And that highlights the absolute urgent need for universal newborn hearing screening and not only targeted high-risk screening in South Africa. So because of our limited resources, our lack of audiologists, there's only 1 audiologist for every 0.8 million people in South Africa. Our lack of hearing healthcare infrastructure, our lack of funding, we end up only screening children who have risk factors for hearing loss. And in the meantime, we are missing 1/3 of patients with permanent hearing loss who don't present with any risk factors. Another very important point, the average age of diagnosis of hearing loss was almost 2.5 years. And it is very late, considering our benchmark of needing to diagnose a child by the time they're 3 months old, so that we can provide intervention by the time they're 6 months old, so that they can have optimal speech and language outcomes. This finding highlights the consequences of the lack of newborn hearing screening and appropriate follow-up in the public sector, specifically of South Africa. Then 28 children, as I've said previously, were foreign patients, and more than 2/3 of them were diagnosed with severe to profound hearing loss for the first time at Red Cross, at ages well beyond recommended guidelines because there aren't audiology services in their native countries. I think, it was something like 20 of these children were already over 5 years old when they were diagnosed for the first time with profound hearing loss here at Red Cross. So in conclusion, there's a large proportion in this cohort of preventable hearing loss, and it highlights the importance of maximizing primary healthcare efforts to treat preventable hearing loss so that we can lessen the burden on the healthcare system in South Africa or in any low to mid-income country. The age of diagnosis of permanent or congenital early onset hearing loss was severely delayed, and we know that this undermines prospects of positive outcomes through early intervention. And then lastly, infant hearing screening services, especially in the public healthcare sector, where 85% of patients are served in South Africa, must be prioritized alongside primary healthcare efforts to reduce preventable risks for hearing loss. And then I would just like to acknowledge my wonderful colleagues at Red Cross Children's Hospital at the Department of Audiology, who assisted with very meticulous data collection for this study. Thank you very much.
Excellent. Thank you very, very much, Silva. That was very, very informative and quite important to have this kind of data in the settings that we practice in. I see we don't have questions at this point in time. If you don't mind, I'll start the questions, if that's okay with you.
Sure.
So I was actually interested in the subsection of ototoxicity. And I was particularly interested in just asking if you've encountered patients who have had, for example, spells of being on anti-TB medication, or even what's documented is anti-malarials as well that are ototoxic. Is this something that you have seen previously? Or is this something that you encountered in your study?
Yeah. So in this particular cohort, most of our patient referrals for aminoglycoside therapy or for TB treatment come from the wards. And they're generally not very good at referring to us, especially, we are not a TB hospital, so we don't see a lot of TB at Red Cross. There are dedicated TB hospitals in Cape Town where those children are referred to. So the majority really of those ototoxic patients were from oncology who were treated with cisplatin. And we have a cisplatin monitoring program here at Red Cross. And we see these children after every second dose of cisplatin. And that's where quite a few of those were beginning to show signs of hearing loss. So definitely ototoxicity or ototoxic treatment for TB aminoglycosides have adverse effects on hearing if it's administered in a high enough dose. But we typically don't see a lot of TB patients at Red Cross because we're not a dedicated TB hospital.
Okay, great. Thanks very much, Silva. I'm going to open it up for some comments as well from around the country and Africa.
Sure.
Perhaps Dr. Shazia Pia, who's the head of pediatric ENT at the same hospital, Red Cross Children's Hospital. Dr. Pia, would you have any comments?
Hi, Tessie, thanks. Hi, Silva.
Hi,
nice
Shazia.
to talk. I just had one question, seeing as so many were, found to have conductive hearing loss. How many of your full cohort of patients actually were referred from ENTs? Of all of the etiologies?
That's a very good question. Let me just quickly go and make sure. I think so. It was over 50%. It was 53% of all of our patients. The referrals came from ENT. So just about half.
And is that within the hospital or even outside of the hospital?
Yeah, that is ENT from all over. So
all
that
over.
is ENT from Red Cross, ENT from Victoria, ENT from all over the Western Cape, really.
Okay, thanks very much. That's all to say.
Sure.
Thanks, Shazia. I see that is it Dr. Tashneem Harris that has raised a hand? Dr. Harris, please go ahead.
Yeah, thanks, Tessie. There's one question from me and a question from Rafael sitting next to me. Silva, that was a very nice presentation. I just wanted to ask you, when patients, when parents bring their kiddies late, what's generally the reason for the late referral? Is it just late diagnosis? Is it that they've not been picked up early? Or, because, one would think that the parents realize that this child is not hearing. So I'm just wondering, is it access? Is it not having sufficient resources? Is it socioeconomic? What do you think the reason is for the late diagnosis predominant?
Yeah, I think, so just from our experience, we have had so many parents coming to us saying they have been concerned since the child was 1 year because they weren't starting to talk. And then we're told, by their pediatricians, just wait, it will get better. Don't worry, lots of children, especially boys, are late talkers. We are still getting that in this day and age, if you can believe it. The other thing I think also is definitely a lack of resources, lack of money to travel, lack of knowledge or education to know where to take this child and when to do it. And then I think denial is also a big thing. Parents want to believe that this is going to get better. There's also a lot of cultural influence within our South African context, where parents believe that, you know, their child is cursed, basically, because they're not speaking or they look different from other children. And the first intention is to hide that and not to seek help, if that makes sense. So I think it's a combination of different factors, and that's why awareness and advocacy is so important, especially for hearing, because it is an invisible disability.
And then my second is, well, it's probably more comment than a question, and then I'll hand over to Rafael. There was a very interesting article. It was actually published here by the UCT audiology guys, where they said perhaps one of the options was to look at the road to health chart and combining screening with the immunization, so that patients, naturally will bring their children for immunization, hopefully, and one will also get an opportunity then to screen them. And one just wonders whether even just a question as to reaching certain milestones is, do you think your child can hear when whatever, maybe something better than nothing.
Yeah.
Sorry, Rafael. Yeah, Rafael was one more question.
Sure.
Okay. Thank you very much, Silva. That's a nice presentation. It's more like a comment, really, that in addition to the deafness of these children, we obtained ethics to do the study, the research on the fact that most of them, they actually have, in addition, balance disorders because of that abnormality in the membranous labyrinth. And so it will be interesting what our research will show, since we already have ethics for it. It's just a comment.
Yes, yeah, I think the outcomes of that study, Rafael, is going to be very interesting, and I think we should definitely pursue it because we have all the data here of the children with sensory neural hearing loss. We can just do a balance assessment on them and see if there's any fallout compared to normal hearing children. Yeah.
Great, thanks, Dr. Harris and Rafael and Silva for those. I'll now ask perhaps somebody else from outside South Africa to comment. And we have Dr. Kenneth Baidu, I see, who's joined us from Ghana. Dr. Baidu, do you have any comments from your side, and particularly even commenting on the sociocultural factors that impair health services in your region?
Good morning, and thank you very much for a very interesting presentation, Silva. I think we in our setting, the reasons for late presentation, as Silva indicated, seems to be the same. I've not interrogated the issue in a while, but from our audiology unit, we also get children with similar conditions, and they even to our clinic, when they do come, and they seem to exhibit same concerns. They thought the children would get better, and even sometimes they follow through with most of the things you do, and then they default coming for further treatment. So I think our social settings seem to be similar. I'm only surprised Western Cape hasn't got what do you call them, newborn screening, because even in our own small setting here, at least those born in our teaching hospital, almost every child gets screened at 6 weeks when they come for antenatal care. And I'm pressing my audiologist to publish the data, but it's still pending. So I think this platform will ginger them and myself to get that data published. Thank you very much.
Thanks very much,
maybe,
Dr. Baidu's.
sorry,
Please go ahead.
I think that, thank you very much for that, Kenneth. I just wanted to add that, so there are a few screening facilities in Cape Town, but it's definitely not reached the point of universal screening. It's still majorly targeted screening for children who have risk factors. So the screening, it is there, but it's not well run, it's not well managed, and it's definitely not accessible everywhere. So we still have a lot of work to do there.
I see also Dr. Zubair Durlakan and Dr. Mohammed Feroz Isa have joined us. Any comments, especially with newborn hearing screening in the private sector in South Africa?
Morning. Sorry, I joined a bit late. Yeah, but in terms of private hospitals, we run screening programs in all the neonatal ICUs. This is for at-risk and non-at-risk neonates. The pickup rate, I must say, is pretty low, and patients who failed initial screening are then followed up with the audiologist and an ENT. I don't know if there's any other protocols that you guys follow that's different from what we're doing at the moment.
Okay, so maybe what's our protocol perhaps for neonatal hearing screening? And there's an interesting comment if you look at the chat function that Dr. Jeffrey is mentioning that do you suggest and emphasize that compulsory neonatal hearing screening should take place and no birth certificate should be given unless screened and passed as a normal hearing?
I love that. If we could pass that law, that would make me very happy.
Okay, fantastic. I think we're reaching our end of this discussion. Any perhaps any closing questions or comments? Sorry, Silva, I just see that Judith has raised her hand, so maybe we have time for her question as well. Judith, you can go ahead and unmute your microphone and carry on, please.
Thank you very much. It was a great presentation. I think the targeted neonatal screening is what the audiologists in Gauteng aspire for. So it's just kids with neonatal jaundice, more than 1 day in ICU, pre-existing congenital defects, or maternal illness. The targeted screening is just about what we're barely able to do right now. But they seem to have good pickup rates at Paraguanath, and I know they're doing a study on CMV and targeted screening and seeing if there are any results with that. That's it. Thank you.
Thanks, Judith. Dr. Zubair Durlakan, I see your hand is raised as well. Please go ahead.
Yeah, thanks, man. Thanks for this interesting information. Just some thoughts, that go through my head when I listen to these 12 talks about hearing loss. Our focus is a lot on sensory neural hearing loss, and there's also quite a few patients out there with and especially in our developing countries with conductive hearing loss. And I think the emphasis on target or getting those kids to also hear has to just the effort has to be more or less the same, and we should be careful not to drive all our efforts only in one particular direction and forget about that big group of patients with chronic otitis media and other middle ear diseases that also end up with hearing problems, and which also need to be focused upon. Many a times we deal with the disease, and then we don't focus enough on the disability in terms of the hearing. So I think that also must be brought into awareness.
Thanks, Dr. Durlakan. Any replies to that, Silva, and any closing comments from your side?
Yeah, I absolutely could not agree more with that statement. As was demonstrated now in this cohort, the more than 2/3 conductive hearing loss patients, and more than 1/3 of those were of a moderate degree, which implies that these children are definitely going to struggle to hear and to develop appropriate speech and language abilities. We definitely need to drive our efforts, probably even more so for children with conductive hearing loss, to treat them timeously, and to try and maximize primary healthcare level services, so that these children can be caught and treated early before they are prone to the adverse effects of a prolonged temporary hearing loss because of middle ear disease. So yeah, definitely that's a big job also ahead of us.
Great, thanks very much, Silva. I think there's maybe time for one more question. Dr. Isa, I think you've raised your hand. Please go ahead.
It's just a question regarding, I mean, this applies to everybody and anyone can actually take the question. At what age would you consider a child to have speech delay? Now, this taking into consideration that a child may come in with middle ear effusions, maybe 3 to 4 per year. It's not persistent, but it's recurrent intermittent hearing loss, and the mom is concerned about a speech delay. Let's say the child is about 2 to 3 years old. When would you consider to actually do something for this child?
So maybe I can answer if I can. Is that all right?
Yes, please go ahead.
Sure. So what we typically do is we rely quite a bit. We have very nice questionnaires that we give to parents, and we have questionnaires starting from birth to 2 years old, that asks questions about auditory behaviors and auditory development, and also speech and language development. So what we do when we are concerned about a child who has chronic infections and intermittent hearing loss, it's very difficult to manage those children with technology such as hearing aids because of their fluctuating hearing loss. So they kind of have to come every week for a test and for readjustment of the hearing aid. So we don't like to do that typically. But we generally give the mom's questionnaires to fill in every month, and then we plot their scores to see if they are performing at the norm for their age or if it's below the norm. And once we see that it's below the norm, we start getting a bit worried. And at that point, we would start thinking about something like a bone conduction hearing aid, or some form of hearing intervention. So to answer your question is, we are always concerned about speech and language development for any child with episodes of recurrent otitis media. And we monitor those children via standardized questionnaires to pick up a problem as soon as it arrives.
Great. Thanks for the talk once again, Silva. I'm gonna close it now here. I think we've had a very, very healthy discussion, and it's great to see during this kind of discussion. So thank you very, very much, Silva, for your time once again, and thank you for everyone that's joined us for all your comments and questions. I think it's really created a healthy learning environment for all of us. What we'll do is that, just to remind everyone, is that we resume our talks next week, Wednesday and Friday. If anyone from not only in South Africa, but from the continent and beyond would like to participate, please feel free to reach me via email, and I can put you in for a talk, or Gerrit Viljoen as well. And we can slot you in for a talk perhaps with an interesting case next month or in October even. But otherwise, take care and lovely days, and thanks a lot.
Sure, thank you.